Okay, we're going to get started. I'm very happy and honored to be able to introduce the panel on root causes and restorative reproductive medicine. We're very lucky to be joined by experts on this panel who will be telling us about their experiences. First, I'd like to introduce Grace Emily Stark. Grace is the editor-in-chief of Natural Womanhood, the online magazine of fertility awareness and women's health, and host of the Natural Woman podcast. Grace is as a trained instructor of the symptothermal method of fertility awareness, a former fertility patient, and a body literacy advocate who wants every woman to understand that her fertility is a feature, not a bug, of who she is. A passionate advocate for education about and access to restorative root cause treatments for reproductive issues, Grace holds a bachelor's degree in healthcare management and policy from Georgetown University and a master's degree in bioethics and health policy from Loyola University, Chicago. Dr. Marguerite Duane is a board-certified family physician, co-founder and executive director of Facts About Fertility, an organization dedicated to educating medical professionals and students about the science supporting fertility awareness-based methods and restorative reproductive medicine. Dr. Duane serves as an adjunct associate professor at Georgetown and associate professor of restorative reproductive medicine and director of the Center for Fertility Awareness-Based Education and Research at Duquesne University's College of Osteopathic Medicine, and she cares for patients via a direct primary care house calls-based practice, MD for Life. Dr. Patrick Young is a fellowship-trained in minimally invasive gynecologic surgery and spent most of his career in academics thus far at Duke University and St. Louis University for 15 years, almost 4,000 cases and multiple landmark publications. He founded the Restore Center for Endometriosis to pay forward what benefited his own wife in relieving debilitating pain and leading to recurring natural fertility, and to enter the conversation among centers of endometriosis as the only center dedicated to treating endometriosis that does not offer to refer to IVF. Dr. Tracy Parnell is a restorative reproductive medicine physician and researcher who serves as Global Director of Communications and Development for the International Institute for Restorative Reproductive Medicine, an organization founded in 2000 to represent RRM medical professionals in the United States and worldwide. She's a managing editor for the Journal of Restorative Reproductive Medicine with a special interest in PCOS and endometriosis, and medical director for the RRM Education Group, which brings leading experts together to train professionals in RRM-focused care. Welcome, and thank you so much.
Thank you.
Grace, I'm going to start with you as a former infertility patient and as someone who's come into exposure to both mainstream and non-mainstream infertility treatments and restorative root cause approaches, noting that the latter prioritizes building healthier habits and hormonal balance. Can you share what your journey taught you about the differences between these approaches, and in particular how restorative treatments focused on long-term health that made you a healthier, happier person?
Yeah, thank you for that question. Can everybody hear me? Okay. Hello? Okay. Now you can, right? Thank you for that question, Deborah. And before I answer it, I just want to say, I know they say never meet your heroes, but there's so many personal heroes of mine in the room today, and what they say is wrong. It's wonderful to meet your heroes and to have them all gathered in one place. So I just want to start by saying that. My story did start with my own infertility journey, and it's really the reason why I do what I do. I have the typical story that so many of us do, where I exercised a lot, lost a lot of weight in college, and lost my cycles. And when they came back, they were never the same. And I got married and was not able to get pregnant right away, despite being 22 years old. I had an idea, fortunately, that there was root cause treatment. I knew enough that I wanted that kind of care, that IVF was not something I would want to pursue. And I'd been fortunate to learn about fertility awareness when I was engaged and had learned to chart my cycles. But it was a year or more of trying to get pregnant and trying to balance my hormones with a restorative reproductive medical professional, and a miscarriage. And the miscarriage is what put me into contact with kind of the conventional infertility treatment side of things, because I didn't miscarry at home. I miscarried while on vacation. And I had an appointment with a doctor who is not my normal doctor, who very quickly, upon learning that I was young, relatively healthy, and had been struggling to get pregnant for a year, almost jumped to offer me IVF. And the interesting part of this is that it was at a military medical hospital, where I was told, they say the military doesn't cover it, but there are ways around it. Would you like to pursue IVF? So this was a doctor who knew nothing about me, about my cycles, about my journey, my struggle to get pregnant, and yet he was ready and willing to offer me IVF almost immediately. And it was such a contrast between the care that I had been receiving with my restorative reproductive trained doctor, just that quick fix, here's what I can do for you, versus the very careful, admittedly slow, but process of getting me healthy, which is what my other doctor was working on. And the next cycle, we changed some things up with the hormonal balancing that we were doing, and I conceived. And that's my 8-year-old today. So, and I've gone on to have 3 healthy pregnancies after that. So I have 4 beautiful, healthy children that I don't know that I would have without the journey that I went on. And it lit a fire in me to give this information to more women so that they knew that they had better options, so that especially when they are offered what seems to be that kind of quick fix solution that can be so enticing when you've been struggling for so long to get pregnant and you have the pain and the trauma of a miscarriage, so that they don't jump for that they hold out, that they know that there's something better. And yeah, that's why I'm here and why I'm doing what I'm doing.
Thank you so much, Grace.
Sure.
Dr. Duane, this is a question for you. You emphasize that restorative reproductive medicine treats the root causes of infertility to restore natural fertility. Can you tell us a little bit more about these approaches and how they address the underlying conditions? What is exactly the mechanism for addressing the underlying conditions, and what makes these methods more effective than some of the traditional, conventional treatments that bypass the root causes? And if you could speak a little bit about root causes.
Yeah, absolutely. And thank you again, Deborah, for inviting us and bringing us all together today. I do want to just start out a little bit with my own story to medicine. I decided I was going to be a doctor November 2nd, 1979, when at the age of 8, I sat at my mother's feet. She was nearly 40 years old and gave birth to my baby sister at home. So from a very early age, I came to appreciate the power of women and the beauty of natural childbirth. And again, that inspired my call to medicine, and in particular, my call to family medicine. I loved the idea of caring for the whole person. As a couple of people have alluded to today, we can't look at people as individual body parts or widgets. We need to look at them as a whole person in the whole context of their family. And as a family physician in particular, we're very focused on prevention and diagnosis and treatment. And for me personally, I had never learned about fertility awareness-based methods, cycle tracking, any of that when I was a medical student, or when I was a college student, and like most college students, presented to student health with a cycle-related complaint and was offered the birth control pill. Knew none of that other than the pill is the panacea for all that ails women. And if you have irregular cycles, we have a pill for that. And if you have painful periods, we have a pill for that. And even as a college student, I knew that didn't make that didn't make sense, but I didn't know any better. And it was when I was a resident at Lancaster General Hospital in Lancaster, Pennsylvania, where I live now, I was first exposed and learned about natural or fertility awareness-based methods and restorative reproductive medicine. And like most women and most physicians, when we hear about it, it was this aha moment, right? Initially, I felt that anger, like that shock and that anger. How come I've never learned about this? And as I reflected on my own story, realizing like, oh, there's more to this. And so I just went on a personal journey to learn more and learned about all of the different methods. I started charting for myself. I was single at the time, but realized this was a great tool to understand my own body. I was able to address my own cycle-related issues through charting, lifestyle changes. Yes, using medications. Sometimes medications are necessary, but it was incredibly impactful. But when it comes to infertility in particular, one of the things, I just came from giving a talk on Wednesday, spent all day Wednesday speaking about 50 medical students from all over the country, which is so encouraging to have medical students that are interested in learning this. And at FACS, so that's what we focus on, is on teaching the students and the healthcare professionals that are new to this. But one of the things that I teach is that infertility is not a disease. Infertility is a symptom of other underlying diseases. And as a doctor, it is my duty to diagnose what is that underlying cause of infertility, right? The way our culture conventionally approaches infertility through IVF is it treats infertility as the disease. And as such, with IVF, we create the embryo in the test tube, right, or in the petri dish, and if in fact infertility was the disease, then that should be sufficient. And when we transplant these embryos, transfer these embryos back, we would expect to have a 100% success rate because we've already created the lives. But the reality is with IVF, the success rates are much, much lower, anywhere from 3 to 33%. And honestly, it all depends on who's calculating. Dr. Young and I share a mutual patient who came to me after having gone through IVF. She had had 8 embryos created. She had had 1 transferred, which, thankfully resulted in the birth of her baby boy, but had 2 more transferred that didn't result. And so she was told she had a 33% success rate. But she had 5 other embryos created that they wouldn't even transfer, and yet they didn't include that in the denominator. When she came to me, she said, I'm either going to see you or I've got an appointment at the end of the month to go through another round of ovarian stimulation and egg retrieval. And what she described to me, before I even saw her for the first time, she reported a classic history of endometriosis, starting at the age of 15, put on birth control for 20 years, had back surgery for back pain that was actually endometriosis related. I gave her Dr. Young's number. I was like, call and get an appointment because you're gonna need it and there's a wait list. And then I saw her and she had other issues. And this is the thing with infertility. It's oftentimes not one factor. It's often multifactorial. And the other thing I want to really emphasize, especially when it comes to infertility, I know this is a panel and a roundtable on women's health and fertility. Infertility is not a women's health issue. It's a couple issue. 30% of the time, infertility is due to a female factor. 30% of the time, infertility is due to a male factor. 40% of the time, it's both. And in almost every single one of my patients that I care for and treat for infertility, I identify and diagnose multiple underlying causes that contribute to the infertility. And this one patient that Dr. Young and I shared, she also did have insulin resistance. And I was working with her with that, with medication and with lifestyle changes. And then I remember calling Dr. Young because when she was there for my first appointment, she's like, this was in December, she's like, I don't have my first appointment with Dr. Young until March. And I'm like, well, that's way too long because you're 40. And I called him, I texted him like, Patrick, can we get her in sooner? And 15 minutes later, his office staff called her. She's like, it's Dr. Young's office. I'm like, well, answer the phone. And she got in to see him a couple weeks later and actually had her surgery even before her first appointment was originally scheduled. And I'll let Dr. Young tell you the rest of her story. But to your point, with infertility, it's multifactorial. Sometimes it's as simple as thyroid. I mean, Teresa Kenny talked about the woman who presented with thyroid disease that was visible. And this is something, again, I know a lot of women and couples are frustrated, patients are angry that their doctors don't know this, that they didn't offer this. And I encourage women, give your doctors grace. We do not learn about this. Until we started FACS and started teaching an elective through Georgetown University, which is the only elective of its kind, this is not in the standard medical school curriculum. Yet through FACS in the last decade, we have trained over 1,000 medical students, right? When I started this work a decade ago, we were doing a study on a shared decision-making tool. We could only identify 500 clinicians in the United States and Canada that were trained. So we've already doubled that number. And the good news is it's brought the attention to medical schools. And so last year I started a new position at Duquesne University, which is the first medical school in the country that is now integrating fertility awareness education at every level of the medical school curriculum. And we need to do that so that every woman and every man and every young girl and every boy has access to this care, the body literacy, the education, the empowerment.
Yeah. Thank you so much. Thanks for your leadership and bringing this to doctors who so need it, right? And I think that's a really great point. You know, we have to develop capacity as women ourselves. We have to teach our daughters. We have to make sure that we're educating in the proper way. But if there's no receptivity in the medical community, then it doesn't. The conversation stops right there.
Doctors are the ignorance of doctors is the number one rate limiting step to the wider spread adoption of fertility awareness-based methods and restorative reproductive medicine. So this is the key barrier that we need to overcome.
Okay, Dr. Young, since we've heard a little bit about your approach, you've pointed out that many of the patients with endometriosis are misdiagnosed with unexplained infertility, and that ablation, which you're going to have to explain to us what that means, leads to high rates of repeat surgeries. While your approach aims for a single effective surgery, which I think you call one and done, is that how you refer to it? Where does endometriosis originate, I guess is a good question. And I think a lot of people in the room we've talked a little bit about potential root causes for endometriosis rather than it being the root cause itself. So I guess that's the first question. And the second question is a cure possible that could eliminate the need for surgery, or is a restorative surgery currently the most promising solution for long-term wellness and fertility for women suffering with endometriosis? Sorry, that was a bit of a hard ball.
That's a lot there. Well, first off, just to say, I'm so thrilled to be here. Thank you so much to the MAHA Institute and to the Heritage Foundation for inviting me. This is just a great moment in our society to be talking about this, and a recurring theme that kept coming up in the previous sessions and now this session is that women deserve better. Women deserve better. Our medical system somehow at one point went off track, and we need to get back to treating patients. In the world of endometriosis, so quick primer on that. Okay, what is it? It's where the cells which line the uterus and are shed during the period are found outside the uterus in a wrong location. And this condition is associated mainly with pain and infertility. It is very common. So the mantra is often it's 1 in 10, but it's way more common than that. There's a TED Talk called The Most Common Disease You've Never Heard of. I love that title. Everybody knows somebody with endometriosis. It's at least 50% in women with infertility, up to 80% or more in patients who do not feel better when taking hormonal suppression for pain, like birth control pills. And from our database at St. Louis University, it's over 90% in patients with both pain and infertility. So the usual treatments, the status quo, I call it, for what is offered to women for pain, which is Band-Aid therapy, we'll talk about that, or fertility bypass therapy, or even this idea that you're going to have surgery every couple of years for the rest of your life once you start to have surgery for endometriosis, is not satisfactory to most women. You know, to the point about where we're at these days with women's health and infertility, you know, I always say that like mainstream or the usual way that we treat women's health would be so boring, really. You'd be writing birth control pills all day, every day for any condition that comes through the door. For endometriosis, we talked about how it's birth control pills usually, which is really using hormones against the body, not with or for the body. Nowadays, actually, it's worse, or it's more aggressive. It's now medications that induce a state of chemical menopause.
Yeah.
In fact, I would say chemical castration. Why do I say it like that? For dramatic effect. but really, Lupron is kind of the original, okay? Lupron is used in men with prostate cancer. Lupron is used as a puberty blocker. And now we're giving this medication to young women and saying this is great for your endometriosis-associated pain. But they don't tell you what it's actually doing. The newer medications are basically Lupron in pill form. It's the exact same type of drug, Orilissa, Myfembree. These medications can have very serious side effects, the least of which are menopause symptoms. It can have severe mood changes. So there's a Lupron Victims Awareness Hub website online where 20,000 women talk about their serious side effects with Lupron. I think it's just a matter of time before we see that with these other medications, these oral medications, because it's the same type of drug, like going crazy type of side effects. So it's Band-Aid therapy at best. You might feel better if you can tolerate the side effects, but it does nothing to actually remove the disease or even prevent progression of the disease, which is a common belief that's not proven, that you need to be on long-term suppression until surgery to keep it from growing or after surgery to keep it away. Neither have been proven, and I'll tell you our data. On the fertility side of things, it's bypass therapy. And the way I will tell you a story about that, just to make the point. So an IVF director herself asked me, who is the most important person in the IVF clinic? Okay, you get a second to think about that. Say again?
The baby that's being created.
That's not the answer given. Okay, first off, it's not the IVF director herself, okay, who got into med school, went through med school, did a residency in OBGYN, did subspecialty training in reproductive endocrinology and infertility, and now owns and directs the IVF center. It's not her. It's not even the patient. She posed the question and then gave the answer. It's the embryologist. It's the person running the lab, because that's where all the action is. This to me was mind-blowing. The patient is not even the one being treated for fertility. And really, if you think about it, she's kind of reduced to just being the one to produce the eggs for the lab. And then the IVF director has really become the one who just transferred the embryo made in the lab back to the woman. But we've lost the patient. 40 years ago, 80% of reproductive endocrinologists and infertility specialists were surgeons. They were still focused on trying to optimize the anatomy and treating patients. Nowadays, in the 20s, it's the exact opposite. 20% are surgeons. We've lost this idea of treating the patient. Anyway, in the world of endometriosis, the usual way to treat this disease is if you see an implant, they try to destroy the implant with energy. It's called ablation. That's the usual way most GYNs treat this disease. The problem with that is if it's widespread surface disease, it's like trying to paint the wall with a pencil tip. If it goes deeper, you're literally charring the tip of the iceberg. You don't get under the roots of the disease to get it out. And people should not be burning near vital structures. So our approach is to cut it out. It's called excision. We cut around it, we cut under the roots down to normal healthy tissue. And we can do that even on our near vital structures. So when they say the rate of repeat surgery after, again, the usual ablation is between 50, 60, 80% in 1 to 2 years, again, expected every couple of years. They're looking back, seeing endometriosis again, saying it's come back. but really they're seeing the same disease from before that was either not treated or partially treated. They're really seeing persistent disease, not true recurrent disease. They're really seeing the same disease over and over again. So we did a study. We tried to get some long-term data, 10-year data, and our rate of repeat surgery was under 5% in 10 years. Because we're actually removing the disease and preventing adhesions, which is where things can stick after surgery, which is also very important. So this is where the idea of one and done surgery arises, which no one thinks is possible. And it's true, there's no cure per se, but I think this data shows some very important things. Number one, that one and done surgery is possible for many women, if not most women, if you actually treat the disease well, optimize the anatomy, even without the need for long-term suppression. Most of the patients in the study did not take any long-term suppression post-op. They were either trying to get pregnant or didn't like the side effects. Number two, that one and done surgery should at least be the goal of what centers of endometriosis are trying to offer patients. I feel like surgeons have given up in a way. They might biopsy one piece to get a tissue diagnosis. They're going to burn what is easy, but then whatever they can't get or is too difficult to get, they're going to put them on long-term suppression, which is what everybody does to try to suppress what they can't get. Or for fertility, they're going to bypass the pelvis and just offer IVF. Or just come back and do it again in 2 years. That's a very different surgical mindset versus, I'm going to try to remove it all at this surgery to avoid the need for long-term suppression because it's gone basically, to optimize the anatomy to lead to natural fertility and hopefully recurring natural fertility, and for the hope of one and done surgery. That's a very different surgical mindset, I would say, on behalf of the surgeon. And I think we've shown a very different surgical result for the patient.
Thank you so much. Thank you. Thank you so much.
We need to train more surgeons.
Thank you, Dr. Young. Earlier on, I think Katie Vidmar, it was you brought up Wendell Berry and the sort of the analogy about the health of the soil. And often when I think about treatments that do not look at the whole patient and do not look at restoring holistic, wholesome health to the woman, that what we get is the same thing we get when we try to force unhealthy soil to produce good fruit and nourishing foods, right? It's problematic, and I think we can all kind of understand that in a very fundamental way. So, Dr. Parnell, my question for you is, you've highlighted the various restorative reproductive medicines, use of a patient-centric approach, where patients actively participating in the charting of their biomarkers to identify the underlying abnormalities that contribute to infertility. Can you talk to us a little bit more in depth about your understanding of root causes and some of these patient-centered approaches and how that actually works?
Right. Well, firstly, again, I want to thank for the invitation. I was there in 2000 when we first presented the concept of restorative reproductive medicine and when the International Institute for RRM was formed. And our goal at that time was to unite doctors, researchers, nutritionists, allied health professionals, fertility awareness instructors under a banner that would be focused on the patient so that we could cooperate and collaborate to be able to get to some of these really important questions and get answers to them. I do want to define sort of a little bit root cause because I think we all use it a little bit differently. I know when I'm explaining to patients, the root cause, I'm really talking about basic medicine. And I have to agree with so many of the panelists, our system is broken. In reproductive health, we have gone so far away from the classic medical model with difficulties that may be with that, but we don't even diagnose and treat. And so when we, in restorative reproductive medicine, sort of use the concept root cause, we're really focusing on how we're explaining to patients what's wrong and how to fix it. I do want to acknowledge, though, that root causes has a different layer as well, and I think they're actually quite linked. If you cannot explain or understand or find what's wrong for a patient, how on earth can we do research that allows us to be able to identify larger, bigger issues? I mean, epigenetics are substantial things. The environment, turns on and off switches in our bodies, and we know that our environment is so toxic in so many ways. That soil analogy, Deborah, if we have unhealthy soil, if we have an unhealthy body, all the other things are not going to fall into place. So restorative reproductive medicine really tries not only to unify all of us together to work to address these issues, but has a staged approach, which you kind of see across our panel as well. And we have activity, lifestyle, sleep, nutrition as sort of a baseline that we address and discuss with the patients, because it doesn't matter if you're going to focus way high up here and the patient is still eating tons of processed food that's really working against what you're trying to do. And then, of course, we have supplements and nutritional supplements and stuff that can help. And then there's the medical approach. We want to take advantage of the science that's available to us to be able to make sure the patient has optimal health and optimal outcomes for what's important to them. And then, of course, the surgical aspect. So it's a wonderful tiered approach that involves an entire team. And the focus of that team is around the patient. And Patrick, I just found it so telling that the embryologist is the main focus. And that's where our system, like I said, is broken. And that's where restorative reproductive medicine, our goal 25 years ago was uniting with the goal to come up and actually become recognized as a new medical profession that focuses exclusively on finding, restoring, and optimizing reproductive health, and which avoids, and this is a bit of an interesting issue right now with the increased interest in restorative reproductive medicine, we are finding people coming out of the woodwork saying, well, we do that. The caveat for being a member and being part of the RRM community is that we avoid methods that suppress, destroy, and circumvent the problem. And so by doing that, all of our efforts are exclusively focused on what is wrong, finding it, and fixing it based on the patient. And then, of course, the outcomes, as Marguerite said, our outcomes for infertility, well, if you have a healthy body, it's pretty easy to conceive and to have healthy single babies that are born at term. And the premature birth rate in the United States and in other countries is far higher than it needs to be. And so much of that could be addressed by this collaborative effort under the RRM banner. People say, it was 25 years, why have we heard of you? Well, you may not be surprised to know that Big Pharma does not entirely embrace us. And that means that much of the research that all of us are doing is paid by our members, is donated, and that does limit the impact that we can do and the changes that we can make. And then the awareness for the patients, of course, if you don't know about something, you can't choose it. And so when we're talking about informed consent, if you don't know and no one's telling you, it's off the table. So I have to keep pinching myself because 25 years ago when we had this discussion and a group of us internationally were all excited about this concept of restorative reproductive medicine. And an interesting tidbit, we were actually in London, UK at the Victory Service Club. And looking back in sort of hindsight, that the victory, I think, is coming now. Boy, there's been 25 years of hard service. And hopefully the victory is coming with all of this movement. And, everybody keeps going an aha moment. And I'm going, well, is that a MAHA moment? And so just really grateful. And hopefully more collaboration is going to do this. And just an interesting point. I liked how you mentioned Lupron as chemical castration. As a tidbit, if you look up Lupron in Wikipedia, not the greatest source for medical information, but you will find it actually is the drug of choice for chemical castration of male pedophiles. It is. So interesting to know how we use it in women.
I love how you say collaboration is key, and it absolutely is. I mean, I practice in Washington, D.C., but refer many patients to Dr. Young or to Dr. Whitaker, and I think, Patrick, we are like 100%. Every infertility patient I've referred to him for surgery has since gotten pregnant, even couples that have been struggling for years. But funding is critical. To your point, the funding to do the research, like the STORM study, the surveillance treatment outcomes for restorative reproductive medicine, there's so much pushback on those of us doing restorative reproductive medicine. It's not evidence-based. Dr. Phil Boyle, who developed the near-fertility method, he says something I love. He's like, just because it's not published doesn't mean it doesn't exist. But we definitely need to do more research and get more publications. But part of that is the funding that's so critical. And IIRRM has been such an incredible leader in that. And we're so grateful for that.
Can I add
So,
something?
yeah, sure.
Yeah, I think it's really important to point out that no one is ever healthier for undergoing IVF.
No.
If anything, your health is destroyed when you undergo IVF. When you treat the root cause of infertility, when you understand, like Dr. Duane pointed out, that it's not a disease in itself, but a symptom of an underlying disease, then you're actually treating women, you're getting them healthier. It was what I experienced as I was undergoing the infertility workup that I had. I was eating better. I was working on better habits. I was exercising appropriately for my female body. I was getting better sleep. Because I was told to pay attention to those things, that those things would have a positive effect on my fertility. I felt myself getting healthier through the lifestyle changes. And then the hormone balancing, the proper hormone supplementation that I was receiving as well. I can absolutely say that my experience of infertility treatment left me healthier. I don't know that I could find a single woman who would say that about undergoing IVF.
The patient that I referred, you want to speak to?
Well, if I could just add to that to say, there was a thread on a group for endometriosis where women talked about how they had known or suspected endometriosis, got pregnant through IVF, but then as soon as they delivered the baby or stopped breastfeeding, the pain came right back to the point that it really affected their ability to care for the child and even bond with the child. And they were like, why didn't, rethought maybe they should have treated the actual underlying disease first. But also, yes, there's an absolute link between wellness and fertility. The better a woman feels, I strongly believe, the better her chances for fertility.
Right.
And what we're talking about here is not just philosophical. It's actually very effective. So when you optimize the anatomy, the hormones, and the functioning, physiology, success rates for pregnancy are up to 70% in 1 to 2 years. That's really, and you're feeling better, and it can lead to recurring fertility. When compared to the success rate for IVF, which is 32%, I mean, that's really good. So this works and works well.
So I guess just a final question in the interest of time. I know that each of you is very passionate about this, and I appreciate all of the perspectives about this, treating the whole person, really reclaiming kind of women's health in a way that doesn't just, put a Band-Aid on something, but restores her vitality and allows the family to thrive and allows her to have children. And obviously this has long-term implications for her health and the health of her child. If there's anything from the other panels, I was just thinking so many of the other panels who talked about nutrition, metabolic health, informed consent, body literacy, they all seem to weave in quite beautifully with this approach. In fact, I feel like each of the prior panels are a part of this approach as well. They're integrated into this approach, which is kind of a nice segue to saying, what ways do you feel in your practices could we make this more accessible to more women who want to choose this option? Do you have any final thoughts on that?
I mean, personally, in my practice, I do a direct primary care practice because with this, it's a time-consuming endeavor, right? Like with women learning to chart, addressing the underlying nutrition, it takes time, and the current medical system does not allow for doctors to have the time to treat this. And it's so important that we collaborate. Like I work with nutritionists and physical therapists to address it. And through facts, like 3 of the panels today are going to be speaking at our fall virtual conference on lifestyle and its effect on the healthy cycle, because sleep, nutrition, exercise, stress, all of those are so critical. So I think you know, a direct primary care approach can open up access, but we have to train more doctors to be able to do this. I have had patients drive 6 hours to see me. I have had patients fly from halfway across the country to come see me. We need to be able to train doctors so that people can access this in their own country. The fact that for the longest time, I was the only physician in our nation's capital licensed to practice restorative reproductive medicine, that's saying something at how just, not ineffective, but just how limited our healthcare system is when it comes to providing this care.
And more women need to know about it too.
That's so key. The power is in the hands of the women and the hands of the people here. You're the advocates. You're going to demand and require change because women are tired, and men, there's restorative andrology, it's under the same umbrella, are tired of being gaslit, ghosted, their symptoms downplayed. And the change, I truly believe, starts with this group and the advocating. And we all work together pretty well. I mean, we're not a huge group, but I send patients to Patrick from Western Canada. There's enough of us that we actually work collaboratively, far better than I think our ART colleagues do because they're in competition. We're collaborative. And we have to do that for multi-center prospective trials to actually be able to have enough evidence to actually shut down any discussion in the future that this is not a valid option because it certainly is. And having that research from all of us in different states, different places across the globe will be definitive in changing reproductive health forever.
But I think it's really important to add that, and I'm borrowing from Katie with this, is that women cannot advocate for, protect, and understand what they haven't been taught to know. And so women need to know that they want this care, and they can't know that they want this care or that this care exists if we take every single 12-year-old that presents at her pediatrician with a painful, irregular period and immediately put her on birth control. Women need to understand that their cycles affect more than just the regularity of their monthly bleeding, that young women on birth control are not laying down proper bone density, their cardiac tissue is not developing properly, their cervical tissue, their breast tissue is not developing properly, and women, girls and their mothers have no idea, and they get put on birth control and they have no idea that there are root cause treatments, and then they see you when they're in their 30s and they're desperate to get pregnant, and they feel betrayed when they find out that this is something that could have been dealt with in their teens, and they could have been able to get pregnant very easily when the time was right for them. And so we have to educate women. That's a big part of what we do at Natural Womanhood, is educating the patient so that they're primed to know and want the services that these wonderful clinicians next to me offer to women. So it's a twofold piece.
Do I have time to add one quick thing? Yeah. So yes, awareness, collaboration. I really try to stay in my lane to do surgery, and I'm taking notes from everybody else to collaborate for the other stuff, for the hormones and the functional medicine and all that. But maybe an idea of developing some kind of network of centers of excellence or something like that. I've said for a long time, or had the idea that research and training for endo is like 30 years behind cancer. So endometriosis is not cancer, but in the cancer world, they talk about personalized care, individualized care, and they have these networks of centers to do research, collaborative research, and training. And I think at least endometriosis or restorative reproductive medicine more generally might take a note from that or something.
Absolutely.
Thank you all so much.
Thank you so much.